Thank you, Mr. Vice President. So hopefully you can see from those numbers that we've taken a data-detailed approach, really bringing the power of granular data to the supply chain and moving supplies based on really what you would call burden of disease and need. If I could just start out by not just going to the numbers at the beginning, but really talking to the community of health advocates, to the community that works on the social determinants of disease and the communities of the historic Black colleges and universities. We really need to improve messaging, and I'm asking them to help us increase the messaging around this. We don't want to give the impression that the African American community is more susceptible to the virus. We don't have any data that suggests that. What our data suggest is they're more susceptible to more difficult and severe disease and poorer outcomes. And we really need to make sure that every household is aware of what it's going to take to protect the individuals in that household that have pre-existing conditions. We could call on the indigenous nations, the real tribal leaders, to also be working very closely to protect the elders of their communities. We know this is more difficult in multi-generational households, and it's really going to call for really unbelievable attention to details of hand washing and protecting others from each other, particularly if you don't feel well. This is really a call to action to the communities to make sure that we get messages appropriately out there so that everyone understands what it's going to take for us all to protect one another. And we know it can be done because we can see these changes. I wanted to go through the numbers at a high level so you understand why particularly these supplies went to these areas to begin with. We talk about attack rates or the cases per population. So in the New York, as a state, they have 7 cases per 1,000. This is the highest in the country. In New York City itself, it's closer to almost twice that in New York City. New Jersey is 4 per 1,000, Louisiana 3 per 1,000, Massachusetts 2 per 1,000, Connecticut 2 per 1,000, Michigan 1.5 per 1,000. The District of Columbia in the Baltimore area now 1.5 per 1,000, and we're watching them very closely. Pennsylvania 1 per 1,000, but we're concerned about Philadelphia. What is allowing us to move supplies based on burden of disease and need is the extraordinary West Coast that has had very low numbers, from Washington that was less than 1 per 1,000, California that is less than 0.5 per 1,000, and Oregon that's even less than that. And it's those states where there's large populations, because of the enormous work that they're doing to prevent expansion and spread of the virus. It's allowing resources to go to these states and these communities and these counties that need more support. And so this kind of data analysis is allowing us to make very intelligent decisions about need, but also really understanding what's happening across the country in the development of the curves, as you have heard about. And so we do see, and I know you heard me caution that over the weekend sometimes there's decreased case reporting, and so there were increases in a series of communities on Monday. We're seeing that stabilize again, and when you look over 3 days, you're starting to see that we may be actually in a series of communities outside of New York and New Jersey and Connecticut creating a much flatter graph. A much flatter curve. So you saw New York and the increase, and then you saw, we're hoping, as Governor Cuomo and the mayor has described, that they're getting to a steady state where the next outcome is going down. But we see across the country, in Detroit, in Chicago, some real, not this extreme going to 7 cases per 1,000, but really staying in the more 2 cases per 1,000 and a different curve parameter then, and it really shows the amazing activity of every American in those cities to really ensure that there's social distancing, and really importantly to ensure there's less socialization between households, and really ensuring that the household really remains independent and protected, and not really at this moment going out into the community or socializing anywhere but a virtual way on computers, by Zoom, by FaceTime. And I think we can really see that in the data, and it's really given us great heart. I want to finish by really talking to my laboratory directors, because you're extraordinary and you've done an amazing amount of testing. Those nearly 2 million tests that we're getting to, those were all done in the last 2 to 3 weeks. But we do have excess capacity. So if all the lab directors could look in their laboratories, if they have an Abbott M2000, if they could get that up and running, we could double the number of tests that we're doing per day. That is a high throughput. The machines are throughout the United States. There's hundreds of them. Right now, about 80% of them are idle. We're going to have a call with the laboratory directors of these laboratories to really ensure this is an automated, robotic situation that they can run. There's over 1 million tests sitting. Test kits sitting, ready to be run. We have 5 platforms of tests. This is one of our really high volume platforms, like Roche, and we're really calling on them to really increase that capacity so that we can do not only increased diagnostic testing, which I think we're doing quite well right now, but also increasing the ability to do more healthcare workers, first responders, community testing, and surveillance. And then finally, you will see, and you've heard about it happening in the UK and other places, there's a series of antibody tests out there that have not been validated. We're working right now very closely with a series of companies that know how to make these tests, that have made these tests for us for decades, for HIV, for a rapid test. They're working on that technology to bring that quality of test, which is in the 90+% sensitivity and specificity, to the American people for antibody tests. But until we get those, if you see them on the internet, do not buy them until we can give you a test that's reliable for all Americans. And we are working very hard to have that happen and bring that to the American public. Some of the tests that may be available on the internet may have very low sensitivity and specificity and give you a false reassurance that you either give you a false positive or a false negative, implying that you may be protected. So please wait until we have those tests available and validated. People are working around the clock to make those available to the American people. We all understand how important that is, because you've heard us talk about asymptomatic cases, and we really want to know how broad that is and how common that is. And so in places like New York City, where I described that they had a 7 per 1,000, sometimes 2, 3, and 4 times any other place in the United States, being able to know what the number of people who never had symptoms but do have a positive test would be really critical at this point, particularly as we plan for any reoccurrence in the fall or in future seasons. Thank you.
Great.